Good morning, good afternoon, good evening, everybody, depending where you are in the world. Thank you for joining us. Welcome to this regional launch of the 3D Commission report. My name is Sandro Galea. I serve as Dean of the School of Public Health at Boston University in Boston, United States. But I'm here in my capacity as chair of the 3D Commission that just wrapped up and produced its report that was launched last week at the UN General Assembly. The report was launched last week, and now we're following it up with 5 regional launches. This is actually the first of our 5 regional launches, with the idea of taking the findings from the report, the principles and recommendations, and having conversations with distinguished scholars and practitioners who are now thinking about how one takes the ideas from the report and integrates them with the particularities of local context. I thought just by way of starting us off, I would share slides and for 2 to 3 minutes, quickly summarize what the commission was about and what the report was about. So I will share my screen. And so this is the cover of the report. The report is available on the website. Anybody can go and download it now from the website. And the commission was 24 people from all over the world, some of whom are actually here on the panel today, who were brought together who brought together expertise in thinking about social determinants, thinking about data and the application of data, from qualitative data, community-based data, all the way to big data and social media, and with experience and expertise in decision-making. And really what the commission asked itself was, how can we better measure social determinants so that we can make better decisions for health? One of the things that we did in the commission was, for example, we did a multi-country survey, and all I want to show you here is that when you do a multi-country survey, you say the majority of people around the world continue to consider healthcare as the most important driver of their health, even though that's at odds with, generally speaking, how we understand the role of social economic determinants today. And that, in one reason I'm starting with that slide, because in many respects, I think that anchors the challenge. Although many of us in rooms like this are accustomed to talking with colleagues who understand the role of social determinants, that is not necessarily where the world is at. Fundamentally, social determinants reflect the full set of commercial forces, politics, neighborhoods, religious, cultural forces, assets and incomes and behaviors that shape the health of populations. And those forces matter much more, overwhelmingly much more for our health than does healthcare itself, even as healthcare is a part of that. There's another page from the commission report where really taking that then and applying it to decision-making. On the left is a graphic representation of how current decision-making happens, where you have a set of competing priorities, competing with social determinants. There are data, all of which sort of ultimately is squeezed into a funnel, and some of it hopefully informs decision-making for health. On the right is an idealized decision-making process where all the elements at local, national, regional, and global that can quantify and can help us understand the characteristics of where people live, work, and play. And those are taken into account in decisions that are made, be they about transportation, be they about housing, be they about the financial sector, because all ultimately matter for health. So with that, and with these set of deliberations over the course of a 2-year period, the commission articulated 6 principles, which are listed here. I'm not going to read all of them, but briefly, the principles talked about the fundamental need to have evidence-informed decision-making, and that evidence-informed decision-making informs investments in all sectors, because ultimately all sectors matter for health. That decision-making has to have health equity at its heart, and that the data needs to serve us well towards these ends. There were quite a bit of conversation in the commission and principles that emerged around the need to have better, more transparent, and more accountable governance informed by data, and to ensure that we include the participation of multiple voices and multiple perspectives, that community members who are essentially where the data come from are well represented in conversations about data to assess social determinants to result in better decision-making. And these principles informed 4 recommendations that emerged from the commission. And very briefly, they are that all entities, national, regional, local entity, should systematically collect quality data to characterize social determinants of health. Oops, I don't know why that's going backwards, sorry. To inform decision-making. The second one is that there should be transparent systems at all national level to collect data about social determinants and to make sure that that is used to inform decision-making process. Third is that we should have monitoring to ensure accountability, that this data-informed decision-making, we actually do follow up on it and we know that it's actually happening and accountable back to the people. And fourth is that communities need to be engaged in the acquisition and interpretation of data to create systems of transparency that make data relevant to communities and decisions that emerge from them relevant to communities. I will stop sharing because now I want to turn it over to the panel, because what's really interesting here is that we have a terrific group of experts who are going to engage in a conversation really around these topics. And I think I'm certainly looking forward to learning from it, and as I think the audience is as well. I'm going to turn it over the screen to Dr. Jeff Sturcio. Dr. Sturcio was the managing director of Rabin Martin. It's running through the commission, also a commissioner, and really has been one of the key intellectual partners in shaping the commission right from the beginning. I think Jeff has brought to this insights from public sector, private sector that have really helped us bring together these focus principles and recommendations, and I think set the stage for what we do next. Jeff, over to you.
Thanks very much, Sandro. It's really a privilege and a pleasure to moderate this discussion. And we're excited to have this regional launch event. It's the first of 5 similar sessions that we'll be having over the next couple of weeks to explore the way in which regional challenges that are being experienced, in this case in the Middle East, may affect the potential for incorporating a data-driven approach to improving decision-making for health that's grounded in an understanding of the social determinants of health. And these discussions will also give us an opportunity to look at ways to build a new foundation of public trust in decision-making grounded in political will, technical capacity, and community engagement. So Sandra has given us a good, quick overview of the findings of the 3D Commission. And now our panelists will have an opportunity to explore these issues in a little bit more depth. And each of them will talk to us about some of the most pressing challenges they're finding today in their work that may keep decision makers from developing and implementing evidence-based policies to improve population health in a sustainable and equitable manner by taking much more cognizance of social determinants and data sources that will help to inform decisions around social determinants. So let me just briefly introduce the members of the panel, and then we'll turn to them. We'll also have time at the end for questions from our audience. And so please just, if you have questions, please type them into the chat and we'll do our best to answer as many of them as we can. So our panelists today are Dr. Maha El-Adwahi, who's the director of the Division of Health Protection and Promotion of the World Health Organization's Regional Office for the Eastern Mediterranean, where she's been since 2016. Professor Fadi El-Jardali, who's the Professor of Health Policy and Systems at the American University of Beirut, where he's also director of the WHO Collaborating Center for Evidence-Informed Policy and Practice, and a founder and director of the Knowledge to Policy Center. Dr. Kauthar Hajat is a professor of public health and epidemiology at the Public Health Institute of the UAE University, and she's a fellow of the Royal College of Physicians and faculty of public health in the UK. Professor Ziad A. Memesh is director of the Research and Innovation Center at King Saud Medical City of the Saudi Ministry of Health, and he's also a former Deputy Minister of Public Health of the Kingdom of Saudi Arabia. And our last panelist is Dr. Shireen Shawki, who's a research professor and senior scientist at the Social Research Center at the American University in Cairo. So you can see we have a group of experienced experts who I'm looking forward to hearing from for their perspectives on these issues. So let me start with Dr. Adwahi. You've been leading the Department of Health Promotion and Protection at the WHO EMRO Center for a number of years now. And so could you tell us the way in which you've been trying to incorporate social determinants of health in the plans and programs at EMRO? And you might also mention the recent Build Back Fairer report and how some of these issues were reflected in the findings of that report. Oh, you're on mute, so. Okay.
Thank you very much, Jeffrey. Thank you very much, Professor Galia, for the nice introductions and for inviting me to be part of this very esteemed panel. Yes, in WHO, you know, since 2008, there was the first report on the social determinants of health, which showed a lot of gaps and showed the importance of addressing social determinants of health in order to build a much better world and to close the gaps. It was said to close the gaps in century. Actually, this was in the title of the report. However, as we know that this was not taken, I don't want to say not taken seriously, because it was taken seriously and there was much appreciation for the report. However, there was not much work that was done in order to roll out this report. Then the years went by, and the general program of WHO, which was developed just after I joined, actually had a whole pillar addressing issues related to the social determinants of health. It's called Healthier Populations. And actually, as of this year, end of this year, they will change the title of people working on health protection and promotion to be the Director of Healthier Populations, because this is one of the pillars of the GEM program of work that really looks at issues related to social determinants of health. So we decided in the region that we have this report, and actually we had very good discussions with Sir Michael Marmot, who led the first and original commission, as I call it, and we had our report, which was launched in March 31st, 2021. So I want to say a few issues about this report. When we were thinking about it, the first thing that came to mind, we want to be an operational and implementable report. We don't want to come with the recommendations that will not be useful. And we wanted to look at the issues that are very relevant to our region. So, you know, the Eastern Mediterranean region, as we call it in WHO, or Middle East, as you call it, because I mean, it has some overlaps. But we have a lot of issues related to conflicts, to cultural issues as structural drivers, in addition to the usual economic, commercial, and natural environment issues that maybe the whole world is facing. We had other issues like the conditions of daily life, which also we tackled, such as maternal child health, employment, healthy aging, and health systems, and so on. What we faced in, let me start by this, and maybe later on we built on that. We were supposed actually to launch the report in November. We didn't, because it's, you know, COVID came, and of course we could not launch a report without something to address COVID-19. And luckily we could even look at issues related to inequities in access to vaccines as well. But we had a number of challenges, and one of our main challenges was actually data, because we're talking about the CD Commission, we're talking about data as being a very important issue, and we did find data, of course, for maternal and child health, non-communicable diseases, and so on. This was much easier, but when we come to look at data for inclusivity, disaggregated data for access to health under conflicts with the cultural, you know, divides and so on, it was very difficult to find data. And we came with very similar recommendation, and I will stop here, maybe elaborate later on, that to what you had about governments having to develop transparent systems for data collection and data sharing, which is not happening. So sometimes they would have some data, but they would not share the data. They would not have it disaggregated. So there must be a system that where we can look at data and be able to look at the health inequities in this data and be able to address them in order to improve the health and well-being of the populations.
Great. Well, thanks. You've gotten us off to a good start. And I want to just emphasize 2 points that I think we'll come back to throughout the discussion. One is that you wanted recommendations that were implementable, and that's critical. So let's think about that. And also, I think what I might say as a gloss on your comments about data is that all data are not created equal. That, you know, you had some data that answered certain questions, but they didn't answer the questions you really wanted to answer about social inclusion and inequalities and a range of things, and that often people weren't willing to, or the holders of the data weren't willing to share them. So that's another issue that comes up. Let's turn to Kauthar Hajat next. And Kothur, you've provided advice to a number of governments, and in your own scholarly work, you've been looking at the challenges of utilizing data to inform decision making related to public health. I was particularly intrigued by the work you did on Wakaya in Abu Dhabi, a cardiovascular screening program that became even more broadly based in Abu Dhabi. Maybe you could comment on that, as well as this general question of how to utilize data to inform decision making.
Thanks, Jeff, and thanks, Sandro. And firstly, just want to say congratulations on publishing the 3D report, actually, which is excellent, but also has some, what I see as very kind of implementable recommendations, and I think will be very useful to using data for decision making. So most of my work has been in the Gulf region, which has its own challenges with new healthcare systems, but also opportunities in terms of the nature of the population. So we were tasked with setting up a national prevention program for cardiometabolic disease. As you may be aware, that all of the Gulf countries have very high rates of cardiometabolic disease, obesity, diabetes, etc. But because the systems are new, this enabled us to really set up a data ecosystem, for example, using financial and administrative data, using electronic health records, data from the education system and other sectors, such as from the police sector for trauma, to set up a trauma registry. So we set up an excellent data ecosystem. We engaged other sectors through a task force where health was actually one of the KPIs for other non-health government sectors. And then we had community engagement, and all of these principles are echoed in the 3D Commission report. In terms of social determinants of health, the financial ones and socioeconomic ones are less of a challenge in the Gulf regions, but the challenge is really about making the environment conducive to health in all its aspects. So the challenges were engaging with other sectors, food policy, schools, urban planning. And so those were key in making anything that we put in place have an impact. So I was really happy to see that the 3D report looked specifically at challenges and principles. And again, these seem to be very implementable. One of the challenges, the first challenges we had, is that there wasn't really, and Maha has mentioned this already, there wasn't really a mindset or a culture of using data or sharing data. And so it took quite a bit of work. So when I joined, when we started that project, Wakaya, all of the healthcare records were paper-based. So by the time we finished, we had mandatory electronic reporting of coded data for every healthcare episode, public and private, coming through a single portal. So obviously we had quite a few hoops to go through to get there. But we did successfully manage to implement that through collaborative working, through the intersectoral working that's mentioned many times in the report. Can't emphasize enough how important it was to have all of the sectors alongside with us on that journey. Other challenges were the resources and infrastructure, and those we had to set up from scratch. Not having policies and regulations, particularly around data privacy laws, which again, very important if we're sharing data to have those set. So in the US, for example, there's the HIPAA regulations, the EU has its own regulations, the UK has its own. There isn't any specific regulation for the Middle East, and so it's important to adopt international regulations around that. Standardization of data coding was key, and that enabled us to put in something that was not short-term, but long-term and stood the test of time. And so we set that up in 2008, and the same data system is still very much fit for purpose. It's had a few tweaks along the way, but it's still going strong. There are a few principles we applied alongside the standardization. trying to put in passive data collection as far as possible. So everyone's busy, everyone has a whole heap of work to do. So asking people to actively collect data is not a long-term solution. So we put in automated passive data collection wherever possible in the health sector, but also outside of the health sector. As I mentioned, education, police, other data sources. We wanted to make the data prospectively collected rather than retrospective, so that it was directly actionable. Intersectoral data collection, and very important to have a two-way stream of data. So if we're asking people to send data on health care and social determinants of health, it's important to feed that back in terms of the utility of that data, but also to help the work and the functionality of other sectors outside of the healthcare system. And one of the recommendations in the 3D report was to have an onus on funders to monitor how data that's collected is used. And I think that's very important for the region. So there are data sources, but they're not necessarily collaborative, and they're not necessarily used in an optimal way. So I'll stop there. Happy to go into any more details.
Well, thanks very much, Kothar. And I want to just emphasize 2 points that you made. One was the importance of this data ecosystem, which you gave us a number of key points about. The principles that you mentioned about passive data collection and being prospective, a two-way stream of data, are all really important. And we're seeing even more now with the advent of smartphones and Apple Watches. There are all kinds of opportunities now using digital data collection to get stuff without people even having to make much effort to provide those data, and then those can actually be used to really hone even further the kinds of interventions that are going to be made. And the other point that I think is so important that you emphasized is the intersectoral nature of the work that you've been doing. Because after all, that's the whole point of thinking about the social determinants of health, that the way people live, learn, work, and play has an impact on their health outcomes. And so that's one of the most interesting aspects of both your presentation and the work that you've done, is that it was very much intersectoral. So let's move next to Professor Fadi El-Jardali from the American University of Beirut. You might talk to us about some of the key learnings from your experience at the Knowledge to Policy Center, because you've been grappling with using data and social determinants to better inform health decision-making. So what's your perspective on these questions?
Thank you, Jeffrey. Thank you, Sandro. Thanks for all the commissioners. I enjoyed reading the report. A lot of key learning, insight, and also very good recommendation. But if you allow me, and I'm going to go quickly, Jeffrey, because I think there is important things when I was actually looking at the recommendations, which is really quite very useful and very good, very relevant to the context of our region. I think just to reinforce some of the key messages, I think we need to acknowledge also there are some existing challenges that we need to tackle. And I think what we've learned from the COVID-19, I think the COVID-19 pandemic is a living proof on that, our health system has been really very much more not equipped to deal with this complex and interconnected issues related to better decision for health. And the reason why, because still in many countries in the region, we're still looking at we have a narrow lens to health. So basically, when we talk about health, we only think health sector. We don't really look at a much more the broader determinant, political, legal, commercial, social, economic determinants of health. And this is really very important. The issue about the intersectoral, multi-sectoral collaboration, we've learned the hard lesson, to be honest with you, that still, unfortunately, when we talk about social determinants, we need really to think about different sectors speaking to each other. And this is, we haven't seen a good governance to promote that communication and learning and coordination. The whole concept of the whole society approach has not been very much explicitly there. Now, I'm not saying this is really quite common, cross-cutting across all the region. But I think we need to acknowledge some of the challenges so we know what needs to be done in order to allow us to actually better implement and more endorse some of the recommendation coming out from the report. The issue about data, the whole concept of data is data as a public good. To what extent we have good governance and sharing, to what extent we have good analytical capacity. Not to say also credible, valid, reliable data. And I think these are important also foundational element for how best to use data and build a good information system that allow us to do so. So these are just more of a reflection on the challenges, because I believe it's important to acknowledge some of the challenges many countries are facing in the Eastern Mediterranean region and see how we can use the recommendation as a stepping stone, jumping off point to engage and deliberate at the country level, at the regional level, in order to influence and promote some of the recommendation or the implementation of the recommendation. Now, some of the learning that we get from working at the K2P Center over the last 15 years, we've done a lot of work and research in health system and policy and decision-making process in the using of in the use of evidence and data and decision-making. And some of the key lessons and learning we got that it's important to understand the political context and the receptiveness of policymakers and politicians to data and evidence. And I believe that is very important, meaning the one size does not fit all when it comes to how best to use data, engage with policymakers and politicians to help them use data and make this institutionalized part and parcel of how we make decisions. So that a lot of learning, a lot of diversity across countries. Second is that the more of the, if we want decision makers and policy institutions to use data at different sectors, we need also to think about developing capacity on the supply side and on the demand side. And I think this is one very important thing that we need to keep in mind in order to make sure that we have enough capacities at both sides in terms of consumers and producers of data. And more of also at the same time, given the different determinants of health, we need to think about how we engage with the unusual suspects, in the sense of how we can go to, it's not only politicians and senior policymakers that make decisions, how we can reach out to policy implementers, how we can, the pandemic showed us and helped us learn that we need to connect with municipalities, to communities, to healthcare workers, to civil society groups. And I think these are important, and they have different modalities of how we can engage them. So building trust, creating demand for data and evidence is very important, but this takes also time, and we need to demonstrate cases. We have to show successes, we have to show failures, and we have to use failures as an opportunity to improve and to learn. But certainly, I think what I would say, some of the learning we got is that we need always to keep working, identifying the right priorities, making sure we use the data at the right time, and we build the story around the data. Raw data does not tell much if it's not really framed in the right context. So working on framing it, visualizing it, using some innovations, harnessing social media, all really, make data much more accessible and well received by stakeholders.
Oh, thanks so much. That, I want to, as I've done with the other speakers, I just want to highlight a couple of the key points you made. And one in particular that I thought was so important is the need to understand the political context of the way in which data and social determinants are presented to decision makers, and that it's not one size doesn't fit all, and that it's really important to understand that the context in which those decisions are going to be made. I also thought your point about data as a public good is critical, and then finally, the importance of building trust with communities and stakeholders to understand the ways in which data are going to be put to use to make better decisions. And those are all congruent with the findings and recommendations of the 3D report. So it's good to know that your experience in the region over the past 15 years, that these ideas resonate from your experience. So now let's turn to Dr. Memesh for a perspective from the Kingdom of Saudi Arabia. You've had a broad range of experiences, first as Deputy Minister for Public Health during the advent of both H1N1 and the MERS epidemics in the region. And of course, another interesting angle is the mass gatherings that come with the Hajj pilgrimage that have impacts on public health as well, on both in the kingdom as well as in the region. So I wonder if you could give us your perspectives on data determinants and decision making.
Thank you, Jeff, and again, thank you, Sandro, for the invitation. It was a pleasure to read the Commission report and to learn from it. The perspective, I think, from the Kingdom of Saudi Arabia is very close to what Professor Kothar has mentioned and what's happening in the UAE. The Gulf countries are young countries. They're very rich and have a good economy, and they have great opportunity to build capacities and improve data-based or data-driven improvement in capacities in healthcare. And that's what we have done in the Kingdom of Saudi Arabia. I think very early on, the Kingdom of Saudi Arabia has realized that having very strong data is important, and analyzing that data in a careful and good way will guide the country into a better healthcare and a better system. And I think when it comes to mass gathering per se, the kingdom has a vast experience in dealing with crowds for many decades. The country has been a host to the Umrah and Hajj. There's almost between 10 to 12 million people come to KSA to perform the Hajj and Umrah every year. Basically, we have people coming from 180 countries, different cultures, different knowledge base, different expectations. They're dealt with in a very smooth way in collaboration with the countries of origin. A lot of education is done prior to them coming to the country. A lot of education done on the ground when they arrive. We use a lot of pictorial education to try to promote healthy practices and ensure their health and well-being while they're performing the religious ritual. Healthcare is provided for free to everybody. So even if there's a requirement for hemodialysis interventions like cardiac surgery or angioplasty, is done for free to all the pilgrims. So there is a lot of devotion in dealing with the pilgrims, because they're coming to do one of the religious rites that is a must for every Muslim capable of doing the Hajj. And of course, this comes with a lot of risk, because when you have people coming to you from 180 countries, there are many different outbreaks and diseases happening in different countries. So the Public Health Directorate in the Ministry of Health has to work very hard with the countries of origin, also with other public health agencies, including WHO, in trying to define what are the risks that are coming from each of these countries and how can we mitigate these risks. So without having data, without having good analysis, without having rapid interventions, things can get out of control. And the ministry has invested into data collection, softwares that are used during these events to collect data live and analyze them live and be able to take interventions very rapidly. You mentioned the issue of the MERS and now COVID. I think this has taught us a big lesson about the interaction between humans and animals, and that these diseases that originate from the animal sources are a major concern for us now and in the future. And the collaboration, intersectoral collaboration between the Ministry of Agriculture, Ministry of Animal, and also Ministry of Health has to be very close. And this collaboration has actually enforced our way of dealing with COVID, because we have gone through MERS in 2012 for a few years. So it taught us that we have to work as a team with other government sectors dealing with the animal side to be able to ensure that there is a smooth dealing with the disease and preventing the spread of the disease. So these are some of the learnings. And I think over the last 15 to 20 years now, we have the Kingdom of Saudi Arabia has been able to produce a lot of scientific data on the process of mass gathering and how they manage the mass gathering events, so that other countries across the globe can take some sort of learning from these experiences.
Well, thanks so much for your intervention. And the 2 points here I'd like to emphasize are that, you know, you've talked about the way in which strong data and diverse data sources have been a really important tool for you and your colleagues in tracking public health challenges and planning public health interventions. And I think that's congruent with what other panelists have said. So that's clearly an important commonality. And I think also your comments about in the reaction to MERS and the COVID pandemic has emphasized the need for teamwork among different ministries, the agriculture ministry as well as the health ministry. And that's, again, one of the themes that we've been seeing about the need for intersectoral collaboration to really take advantage of all of the knowledge we can gather from data about different social determinants of health. So I think those are both important points. And I'd like to turn finally to Shireen Shawky. And Shireen, let me just ask you, how have you seen over, you know, you've had many years of experience working in research in this area in the region. How have you seen the evolution of the role of social determinants in shaping health policy and programming? And what do you think are some of the directions we might see things going in the coming years?
Okay. Thank you, Jeff, and thanks to Sandro. It has been really an honor to be part of the 3D Commission. Actually, research has been guiding policies and actions all over the years. But over the past 2 decades, the research findings that came out from our region clearly made it clear that health inequality was evidence, and sometimes on rise. The public health research and the social research and the development research were running in silos. Research had a narrow focus, and health was still thought of as health systems business. Research now in the region speaks to these challenges. It takes a broader scope, and let me share with you one example of chain of research in this direction that we are working on in the Social Research Center of the American University in Cairo. Our main goal is to produce evidence for guiding equitable policies and interventions. We have several steps in this direction. And our first guiding question as early as the year 2008 was, how can we apply a social determinants of health approach to guide policies? We worked very closely with the Global Commission of the Social Determinants of Health, as our director, Dr. Huda Rashad, was one of the commissioners. We conducted several workshops, and the recommendations were to build the knowledge base on health equity. We then focused our research on making health inequality evident, but this was just a technical exercise that made us realize that it is not a matter of measuring health inequality. It's a more complex process. We need a full approach to link the health outcomes through the lengthy pathway to the root structural causes. This has stimulated our partnership with WHO EMERO. Our emphasis was on governance and intersectoral action for health. We used health not as one dimension of multidimensionality, but as a litmus test of fairness to build a social determinants of health inequality approach. Our approach was founded on the Commission of Social Determinants of Health framework, and we moved step by step to put the pieces of the puzzle together to come out with social framing of health, which was still theoretical. And this inspired our partnership with UNFPA AFRO. The overall objective was to support governments to inform integrated intersectoral policies and programs to address sexual and reproductive health inequities in the region. We engaged with national partners. We applied our approach on 5 countries of the region, and many lessons were learned from this research. First, data sets were not always comprehensive, consistent, or up-to-date. Priority health conditions were not necessarily priority inequality conditions. Successful service coverage does not always mean fair distribution of services. The disfavored were not always the poorest quintile and rural residents. And the progress in health does not always mean progress in reducing health inequality. From here, we were all on the same page. We as countries need governance, policy, and information reforms, embracing the principles of human rights, social justice, and health equity as cornerstones for the realization of the Sustainable Development Goals in our region. We are still working in this direction, inspired by the Commission of Social Determinants of Health regional report and the 3D work. And our findings make us interested in the information system for health. We realize that it is not just a matter of data collection or a matter of data sources, but it is a whole system. And we are currently working on a project that calls for a move from health information system to information system for health. Our objective is to make available the kind of data that can monitor national success, that can help move from a narrow health policy focus to guide the full package of national policies and action. So research has always been working hand in hand to guide a social determinants of health approach, applying an equity lens. I will end by saying we have palpable challenges that make the policy uptake of research slow, but we have opportunities and we should make use of these opportunities. Thank you.
Well, thank you, Shireen. And I wanted to just emphasize 2 points you made. First of all, the health equity frame in which you've been looking at these issues, I think, is really important. And we may want to come back to that in a moment. And the other, you made one of your last points was the need to have not so much improved health information systems, but better information systems for health. And that seems like a subtle change, but it actually is much more fundamental, because that change in perspective is consistent with the broader view of bringing in all the social determinants and an intersectoral perspective to improving health equity. So I thought those were 2 really important points that you made. Well, we have about 15 minutes for some additional discussion. I wanted to just start with one question from our audience. Zainab Khader asks that we've mentioned collecting large amounts of data, and the question is, are these data available for researchers, and do those data adopt an equity lens with sufficient disaggregation to allow thorough investigation of social determinants and health equity? So that was a question particularly for Dr. Zaid Memesh, but others may want to jump in as well.
Absolutely, I think this is a very good question, and I think the Saudi Health Council is actually working on a system of disaggregating the data and trying to make it available for researchers to be able to use it without compromising the people who are collecting the data, or at least divulging some of the details that are not supposed to be divulged in the research analysis. So this is something that is being worked on a national level to ensure that, as was mentioned by other panelists earlier, trying to sort of make sure that the data is being handled in a good way, and the analysis will make an impact on how we improve healthcare in the country.
Good. Anyone else on that question?
Jeffrey, so just wanted to, if you allow me, and this is not specifically on this question, but I think one thing that has to note is that, I think what we're starting to see in our region, there is certainly more demand for data. I think this is a great opportunity. I think the challenge we have is the existing capacity first. Second, that some data that's being requested are not available. Some policymakers are starting to ask, difficult questions about, how much we know about this. And let me give you an example. If we're talking about whole of, health and all policies approach. So meaning we need to start really trying to work with the Ministry of Finance to convince them that they have to invest in air pollution, for example. Well, sometimes they will ask how much data we have, how much local data we have, what would be the return on investment in really more doing some intervention related to air pollution, because this is a determinant of health. Same thing when it comes to physical activity. Sometimes, there's a lot of areas I think we should be ready as policy analysts, researchers, and others, that we will be having difficult requests, difficult questions for important data that we need to create the system in order to allow to cater this information. So we don't want to only focus on the problem that we need to use, or we need to promote the use of data. I think we are almost there. And many of the countries, including the Gulf, they are making fantastic work. A lot of successes that can have a nice ripple effect on other countries. We've heard Saudi Arabia doing fantastic, mega transformation. We heard also about Abu Dhabi and others. This is great, but I think we have to also look that the problem is not only more data into policy. That do we have this data? What would it take to have to create that data so we can actually implement the recommendation? I think this is very important observation to note. Over.
It's an important point, and actually a couple of other questions from our audience relate to this. But before I go to those, I wanted to just turn to Kauthar and then Maha.
Thanks, Jeff. So I wanted to reiterate what Professor Memish said about data privacy, and that's very relevant. And then second part to the answer, I think, is about looking at publicly available data, and again, moving away from actively collecting data to utilizing data that's already out there. And prevention is moving outside of the health sector, and it's moving towards the direct-to-consumer model. And so that data are all around us. It's in the consumer digital footprint, it's on wearables data, it's on sales data. How much tobacco are people buying at national level, at regional level? It's in health insurance data. And search engine data, for example, for infectious diseases, we can use search engine data to predict and really look at when people are getting symptoms of infectious disease. So I think we really need to think broad and think about all of the available data sets. And these publicly available data sets don't have data privacy issues necessarily, because they're already dealt with by the collecting source. And so I'd encourage anyone coming into this field to really look at a broader level than the healthcare sector.
Yeah, no, it's an important point. Interestingly, one of the arguments in the 3D Commission report is that we need to go beyond just the health sector to understand how to have a more nuanced understanding of how social determinants have an impact on health outcomes. And what you've just told us, and Dr. Fadi and Dr. Memish as well, is that we also have to look beyond just health data to understand how health outcomes are affected by social determinants. And you've given us some really good instances of where you can find other kinds of data that are relevant. Maha, over to you, and then Shireen.
Thank you very much, Jeff, and thank you actually to all the speakers, because the many parts of the question have been answered. So I actually wanted to say exactly like Kauthar was, not exactly, but what Kauthar was saying, that we do find data relevant to the social determinants outside the health sector, and we need to bring it in and to use it in the right way. And the example that Fadi actually mentioned about the environmental health and how we can convince policymakers about the importance of tackling air pollution and the effects on non-communicable diseases and actually on mortality is very difficult, because we don't have this kind of data available at our fingertips all the time. So we actually need to also advocate for the right kind of data that is needed. We need to find the data that responds to questions that are relevant. When we are talking about health and well-being, we have to understand that health is not sickness. It is basically the non-sickness, the state of physical, mental, and social well-being. So actually social is in the definition. And when we look at health and well-being, it is in all these sectors. Both Kauthar and Fadi actually, and Dr. Memish as well, they mentioned the issue of intersectoral collaboration, whole of society approaches. And I think this answers to the first question that we have also in the chat. So if you allow me just 1 minute on this. I think every public health person needs to get the frame of thinking outside just providing health services. We have been focusing for a long time on health systems. But even the health system, even the models that were done by WHO, they miss the community part, the engaging others, the whole of government, whole of society, and the community engagement, community leaders. These are essentials now, and without them, we'll not be able to build trust. We'll not be able to collect the data that we really want to do, and we'll never be able to achieve health and well-being for all, which is what we're calling for in the EMRO vision, for example, 2023. But it's also when we look at the Sustainable Development Goals, when we look at goal number 3, it says health and well-being for all at all ages. Is this something that we can do only through the health system? I very much doubt, and I'm sure many of us agree on this. That's why, as public health professionals, we have to look to the issues related to the social determinants. I will not just say social determinants, but I would say all the determinants of health, collect the right data, and also package them in a way that we can take them to the next level and inform the decision makers in the best way possible to ensure health and well-being for all.
Thank you. Very important points. And Shireen, just quickly, because we only have a few minutes left.
Okay, I will build on what my colleagues have said. We need a full system linking the different sources and providing complete and comprehensive data. And also, I will stress on the need on data utilization. It is also very important. All what I see now in the national and regional reports, they are very traditional. They do not provide any evidence on the interlinkages between health and the package of public policies. Policymakers just receive the same messages with single sector recommendations. In simple words, there is nothing new that shows the complex interlinkages that can help policymakers change their approach from single sector policy approach to intersectoral action. So we really need to change our way of presenting this data to policymakers to show them this interlinkages and to steer the intersectoral action. Thank you.
I think that's also a very important point, that policymakers will only be able to make decisions based on what they know and what they see. And so we have an obligation to present data in a way that will lead them to different kinds of conclusions. I'd like to just end with, to ask each of you to respond briefly, and it's this is an impossible task when you hear what the question is. But one of our participants has asked, how would you recommend, as public health practitioners from the MENA region, that we elevate the recommendations by the 3D Commission for the Middle East and push forth an advocacy agenda to drive data for the greater good? So that seems to me to encompass many of the questions we've been asking, but if each of you could just give about 40 seconds in response, that'll will take us to the end of our time. So let's start with Maha, and we'll just go through the group.
Very briefly, believe in what you're doing and be patient. It takes time to change. Things will not change overnight, and things will not change if we stop doing what we have to do. So we have to continuously, we have to sustain our efforts, and we have to be patient and make sure that there is light at the end of the tunnel that will happen. But unless we put all of this in place, then we will not be able to move forward.
It's good advice. Kothar, let's go to you next.
So I would say look at the opportunities, look at what data are available, but look at the quality of the data, because poor quality data can be very damaging. So please look at the quality of data. And if you have data, please use it, because even just measuring something, just measuring healthcare leads to change in itself without any other intervention. So yeah, if you have data, use it.
Great, thank you. Dr. El-Jardali.
Well, I think it would be good. There's a lot of good things from the report, and I do believe this has to be the next step. Would be how this report will be stepping stone for further discussion and deliberation among a diverse set of stakeholders at the country level and the regional level. So what I'm saying that it would be good perhaps to have academic institutions that can maybe partner with other institutions in order to host a dialogue, national dialogues or so, where they can bring different stakeholders from the government, non-government, civil society groups, and really try to mobilize and to raise more awareness, to bring different perspective, but also to develop together collectively a customized action plan that can be taken at the country level to take those recommendations forward. I do believe in champions. I do believe in institutions moving it forward. I think that's how I see this can actually, trickle down to some tangible efforts at the country level. Over.
Great idea. Dr. Memesh.
I think I agree with what has been said so far. I think adoption of the Commission report by the academia and the government is really important, and also investment. I think investment, the vision of the country should invest into collecting data and trying to sort of establish equity. And I think this is really important. And I'm glad to say that in KSA over the last few years, the Vision 2030 is actually investing significantly into good data collection, also analyzing the data to make for better health outcome in the country.
Thank you. And Shireen, you'll get the last word.
Okay, I feel we need to build on the opportunities we have. We have two great opportunities. First, the SDGs. All countries must achieve the 2030 vision, which stresses on the interlinkages between the goals and puts health at the heart. The second opportunity is the COVID-19 model that we have seen in our region. We have seen leadership by the head of the state or the prime minister, and all ministries engaged to contain and to prevent the spread of the infection. And I will end by saying, provide the right evidence. What cannot be measured cannot be managed. Thank you.
Thank you. Well, I want to thank all of our panelists. This was a very lively and wide-ranging discussion, lots of terrific ideas and suggestions. And I want to thank you all for your participation. And now I turn it back to Dean Galea for some closing remarks.
Well, thank you, everybody. I learned immensely from listening to this. And when one launches a report like this, and one makes the effort over a few years to culminate in a report, the hope, of course, is that the report informs, influences, and shapes thinking. And I think what we're seeing in this panel is that perhaps the report is a platform and a scaffold, and people are building on it, and ideas are building on it. And I think I was really most impressed by the granularity of these ideas and making it clear how the notion of bringing data to bear on social determinants to inform decision-making can have a very real footprint in the region and can actually become a notion that becomes lingua franca to a place where it actually is something that we do not even think about. It's just how we do things. So I really want to thank all the panelists. I want to thank all the panelists for a terrific set of presentations and discussions. I want to thank Dr. Sturcio for outstanding facilitation. And I also want to thank the participants. I think these things are as good as the participants' engagement is. And I actually enjoyed learning from the questions and listening to the responses. So everybody, thank you for being a part of this, and thank you for